Sami.
Yes, sir.
Yeah,
I invite Dr. Swami sir to introduce our professor, distinguished luminary from Tanjore Medical College, to introduce him to the audience.
yeah, it's a distinct honor and a great privilege to introduce Dr. Mohandas, to this audience. Um, it's a little bit, I would say, emotional also, considering how much of an influence and how long we have known each other. Um, Dr. Mohandas is a distinguished nephrologist, as you all know. He um, uh, published many papers, and he has been the heads of medical associations in Tamil Nadu. Currently, I heard like he's also the head of the Tamil Nadu nephrology chapter also. And so he has vast clinical experience, outstanding clinician, and currently he works in Rohini Hospital after his retirement. He trained from MMC in Chennai. But not to repeat his CV, but more on personal note, I want to share a few anecdotes about Dr. Mohandas. His house was just opposite, is actually is opposite our house where I grew up as a child. So our families knew each other for 3 generations. So my grandfather will visit his house and get the OC Hindu newspaper from his house. And so any little ailments and everything, we'll go and see him, and he really took care of our entire family. And my parents are very close to him and his wife. And his wife will come and spend quite some time in our house. In our house, and so there are like multiple such connections. And Dr. Mohandas inspired was one of the first inspirations, I would say, for me to start thinking about nephrology. Where which field I'll choose. And you're in medical school and all. Then I'll be going in a cycle to college, and then he'll stop me. Swami, என்னடா பண்ற? புக்கெல்லாம் எடுத்துட்டு போறேன், இതൊക്കെ சொல்லி பேசிட்டு இப்போது every time he'll stop me and talk, and always connected very, very fondly. And that connection persisted even after I went to Chandigarh and after I went to USA also. And his daughter Priya and my younger sister, they're very good friends, and they book tuition from my father. So multiple level connections between our families, and professionally and personally. So it's extremely special. And Dr. Mohandas was telling me is this incredible experience, with acute renal failure with the snake bite and bass bite and other kind of topical nephrology over the years of his practice. For me, this is something I've seen only when I was in PGI training. After that, in US, these type of conditions you don't see. I'm sure, like I'm going to learn a lot, listening to Dr. Mohandas today. So I want to stop here so we'll have time to listen to Dr. Mohandas here. But again, thanks again, and it's a distinct honor and privilege. Welcome, Dr. Mohandas.
Thank you, Dr. Swami, and thank you, Dr. Venkatesh, for permitting me to meet all our friends. Good evening to all. It's a privilege to talk before the learned audience because my experience, 1 decade in the nephrology, because I was a single person at the time after Dr. Soundarajan left to Chennai. And we see a lot of acute renal snake bites because most of the snake bites are referred from the Karur to Tanjavur. Here from this Mayiladuthurai, Viluppuram, up to Viluppuram, they used to come here because there is no medical college or no nephrologist at the time. So all the patients are referred here. So what are the things we have done, we can share with it, because this paper was presented in a Asia Pacific Congress of Nephrology and also in the ISN, the WCN, and the work we have done it. So nearly the 200,000 patients are now it has been increased. Today, Hindu, I notice it is more than that. Most of the patients die of renal failure due to snake bite is 35,000 to 50,000. Now it has been increased. There is no decrease because mostly the farmers or the workers are affected by this snake bite. So in the study we have conducted, because the only paper was available at the time was Dr. Chuk article in ISN, acute renal failure cases. In this series, he has noticed the snake bite cases. Then we started examining all the patients. How this is Salem in 98% of the patients and Tanjavur 86.8% in 1 year. Salem is 2 years and Vellore is 2.2. As per the records they have noticed, there is no latest data available for me. So it is a preventable causes. If it is detected earlier, give anti-snake venom, we can, because of the side effects or toxic effect of this anti-snake venom, most of the patients are not given the anti-snake venom properly in the primary health center or the district headquarters. So most of the patients land up, or in the villages, that because of the native treatment and putting the stone on the bite site, all the things, all rubbish things we have noticed. Common snakes we notice is Russell viper and Achis corneatus. So now the following the bite, the breakdown of endothelium results in significant loss of fluid in the spaces, capillary leak syndrome. You know that because of the capillary leak syndrome, there is an edema and the patient have hypertension. Most of the patients, because of hypertension, have the cardiovascular collapse. What are the enzymes or the component of this venom is phospholipase A2, which is one of the component of venom, causes changes in the cell membrane permeability that result in red cell ghost, hemoglobin deposition, and liberation of creatine phosphogenase for the muscle cells. The 20 or more components are now today I have noticed more than 18 components in the been detected. So because of the glycoprotein that factor acts on this factor 10, arginine ester, because of the hyaluronase, the tissue damages, and elaptin is which activates the prothrombin. You know that DIC is the main problem with the snakebite cases. So phospholipase A2 increases the hemolysis, increases vascular permeability, hyaluronase already spread of the venom, and tissue damage. Tissue necrosis, we have noticed. Hemorrhaging, which damages the blood vessel. So there is a spontaneous. This is a simple mechanism and various components are present, but this is a culprit which causes the DIC and also the capillary leak syndrome, and then there is a profuse bleeding with the site. So the main mechanism is because of hemorrhage and hypertension, intravascular hemolysis. Most of the time patient have hemoglobinuria or the rhabdomyolysis, DIC, and direct effect of the venom or the reaction to the antivenous protein. This the paper was presented by Dr. Vimala from the Trivandrum, the reaction to the antivenous protein. She has collected all the patients who have taken the antivenom and the blood and they preserved it. And after collecting all the things, she found that the protein bound of antivenom is very less, and that by releases the from the protein causes the patient may be all right with 3 or 4 days. 5 or 6 days, the patient once again have a bleeding tendency because of the release of this venom. This has done the research work on this. So main pathogenic mechanism in the snake venom nephrotoxis, direct nephrotoxicity, hypertension because of hypertension, ischemic kidney disease, the bleeding in the short circulatory collapse causes ischemic renal disease. Septicemia, I told you that they put all the sand, all the dirty things in the bite side, and patient have the infection, cellulitis, and they end up with septicemia. Hemolysis with the hemoglobinuria that causes the cost nephropathy. So how to diagnose this patient? ST is important, very, very important, because nowadays this is a season. The patient usually have the snakes will be in the huts. Most of the patients are living in the huts, in the villages, and the snake will be there. The pediatric patients, more than the pediatric patients, they have a bite, and they will brought to the um, our OP or the OP. There is a swelling without any bite mark. And then we have to see for the bleeding time, clotting time, and prothrombin is prolonged. Then we suspect the patient is having the snake bite, or if there is a lymphadenopathy, we have to suspect the patient is having snake bite. So early morning bite is always quite common with this, because they go to the toilet in the open ground with barefoot, they have this bite. This is the history of the patients. So lymphadenopathy reduces the glomerular filtrations and hematuria, high-colored urine, and then the urea creatinine was elevated. We have to exclude the other causes of it. Visually, history taking is very important, because Anjur Medical College is a referred center. The patient may not have taken the anti-snake venom, because the primary health center, they give antibiotics and tetanus and ask them to observe, or they refer it late. So most of the patients should come in late stage only. Those who are referred earlier, we give anti-snake venom. Two tragedies are strategies for this anti-snake venom, whether we give high dose or the low dose. So high doses, the 2 vials of anti-snake venom diluted in 100 ml of dextrose or saline. Usually we give saline over 2 hours, followed by 10 vials in 500 ml of saline for 4 hours. Then we have to monitor the bleeding time, clotting time. So clot time is prolonged. We can repeat the anti-snake venom till the clotting times comes normal. Low dose tragedy is first dose we give 2 vials, followed by 4 vials, 4 hours. Then mortality rate and percentage of cases requiring dialysis is more in high dose group, because this paper was published in the JP in the 2004. The same criteria is because the low dose tragedies is anti-snake venom is a sequent protein causing subclinical toxic effect in patients with multi-organ involvement, because already the patient is on hypertension with muscle necrosis. We give this equine protein that can precipitate the toxic effect, and the patient have the multi-organ involvement. So today's Hindu, I have gone through this 20th century on the snake venom. What he has written is previously they collected the venom, and then they inject it, and then they prepared that is poison from the snake, and they prepared it, and then they given for the as a venom as a powder form. Now, the recent studies of the 2025, they put it in because the component of this snake venom differs from the place to place. They have noticed the place to place, the Rajasthan and Orissa, they noticed the same venom, same snake, but have a different component of this venom. So they have injected to the camel and taken blood and then injected in the virology, and then taken away the DNA, and then the encoding the DNA, they produce the nano antibodies. They are preparing the venom. This is today's Hindu gone through this article. So it is something is research on this anti-snake venom. So regional variation of venom, the chemical composition of venom, the same species varies place to place. That is the observation they noticed, and then the nano-antibodies are formed against the venom. So this is the publication from the government standard treatment guidelines, management of snake quick reference guide, and the Government of India have published in January 2016. And for this management of same thing, we have to take the rest and screening for the hemoglobinuria, myoglobinuria, and urine output to be monitored 1 ml per kilogram body weight urine output, give fluid challenges, and adult patients can be given 2 liters of isotonic saline over 1 hour. If the patient is in hypotension, patient we give a fluid, or we use to give blood, or the most of the patient is bleeding is not controlled, we give FFP for this type of patients, and then we monitor the that is jugular pressure. And if the patient is going for this pulmonary edema, we stop the fluid challenge. Second thing, this is very interesting. I came to know that we used to use sodium bicarbonate because in the copper sulfate poisoning used to in GH, as my doing PG, the forced diuresis, forced alkaline diuresis for this copper sulfate poisoning, we used to give most of the patients who have this forced diuretic because alkalizing the urine prevent the tubular necrosis. For that, we give normal saline along with sodium bicarbonate, and then we give diuretics or ringer lactate with sodium bicarbonate. And then because the patient will have this hypokalemia because of giving this bicarbonate, and they have the sodium, we give the potassium chloride to be monitored. Not all cases, because of muscle necrosis, potassium level will be high. So we cautiously give the potassium chloride. Usually we give mannitol over 20 minutes, whose cycle completes, and then monitor the urine output. This is the guidelines given, but we used to give normal saline with the sodium bicarbonate with high colored urine, and along with the diuretics or the mannitol in the patient, we used to give along with the higher antibiotics. So this is a thing we used to give. IV fluids, blood transfusion if the swelling extends and then requires vigorous fluid correction and monitoring for the renal failure. We have to check the patient. If the patient came earlier, we give ASV. Along with that, we monitor the urine output, and then if the patient is having hematuria, we give the along with anti-snake venom, we can give the post-diuresis, post-alkaline diuresis, and the patient in profuse bleeding, we give blood transfusion, also FFP in these patients. Higher antibiotics, those days we used to give this metrogyl, this anaerobic available. Now so many drugs have come, but those days only the few drugs are available. In government college, the availability of the antibiotics is very less. So the treatment of cellulitis, elevation of limb, mannitol over 1 hour, it reduces intra-compartment pressure, limits muscle damage, may prevent renal failure. Decompartmentalization, this is the study we have conducted. I will show it. The fasciotomy is topical surgery gone through this Roger Bailal. They have studied in the army people. Army people, they have crush injuries. They started giving these the decompartmentalizations, fasciotomy in those patients, along with the IV fluids with the alkaline diuretics. The patient recovered from this renal failure. So we gone through this study, and this is 2002, and our experience and is managed by university. This is the Russell Viper, and then the crate, that. This is statistics shows that this is the total number of patients here. That this is the poisonous, and this is sorry. 2011 to this, nearly 800 cases. We daily used to, that is per year, we used to see number of cases. It's been because it's a referred center, referred from Pudukkottai, and Karur and Ariyalur belt is and Mayiladuthurai is more common for this snake bite patients, more number of patients because of the canned sugar. You know that this is a season as December and January and December, November, December is high peak because one is the canned sugar because of the smell, the snakes in the canned sugar that is a field, and this is the harvesting. This is a season for harvesting because of Pongal and Pongal season, and they have the snakes will be there the fight. One of the interesting is one of the whole family has been bitten because his husband is in the top of the tractor, and our daughter, our wife is giving the bundle of sugar can to his husband, and he is in the tractor. So the snake bitten her husband first. He thrown the snake out, and it falls on his wife. Once again, there is a bite. Small boy is sitting in nearby the mother, and he also bitten. All the three came, but husband is very sick because the venom is more. Number of venom is more, and fortunately they came earlier, and we saved the whole family. And there is a number of snake bite cases are increased. We have seen because it's a referred center, and all the other non-poisonous, you know that water snakes and other snakes is more. This is a poisonous snakes. This is a statistic. I think that so nobody had it. This amount of snake bite cases. So we managed it conservatively. 20% of the patients managed it conservatively. I trained my PGs. I thank Dr. Doraraj and C. Bose, who deputed postgraduates to because I was alone. I was the ward boy, I was the dialysis technician, I was the nephrologist. So, but fortunately, Dr. Dorraj and A.C. Bose deputed posting for the PGs. So I trained all my PGs peritoneal dialysis. So they give once the snake bite comes, I will be given call over, and I have to go and start the peritoneal dialysis. If the patient is having profuse bleeding, we have to take up for the hemodialysis. My PGs, I have trained my PGs, so they are well trained in the peritoneal dialysis, and most of the patients recover with one or two peritoneal dialysis. And whereas the hemodialysis, 10% of the patients, those are having a profuse bleeding. And in that case, we put a femoral catheter and we start the dialysis because those days the jugular catheter is not very famous. We used to give subclavian catheter those days. To analyze the snakebite cases and measure the compartment pressure, those with the cellulitis. This is our study. And then they assess the prognosis relation, early management of the compartment syndrome. This is our study. This same thing was published in the guidelines book on 2016. I've shown you the previous reference. We go through this Murthy and al. Regarding that. We are given the designation to the MS postgraduate. So she is interested in doing this project. So the compartment pressure is a pain, pallor, paresthesia, pulselessness. This is the guidelines given in the guidelines, latest guidelines. Say small kids have the snake bite in the leg, and so massive edema is there in these patients. So we measured the compartment pressure of the cellular side by syringe manometer technique. This is the technique they adopted in the Murray and al. The same now the guidelines also I have noticed the guidelines also given this is 2016, but I have done it in the 2005 or 5 itself. Then this is the manometer. We put the catheter dialysis. This is the guidelines given in the guidelines book. So here we put a needle in the sterile saline, withdraw the plunger and fill the distal lobe of the intravenous tubing. The meniscus visible at the air saline. I'll show this. This is the thing. We put here, you know that AV pistol needle, I put it AV pistol. Usually they given 18 gauge needle. They put the needle here, needle, and one syringe is connected to the manometer, big bomb manometer, and here we use connected to this the big bomb manometer, and this is connected to the cellularity site. So we three-way cock, then we give you a pressure. So we filled with saline, and the saline is filled with this saline. And once we close it, when we close it, this and the pressure in the then once we put the needle, the pressure in the needle transmitted here and recorded in the manometer. This is the syringe manometer technique. That is now, one side is connected to this syringe, another is connected to the needle. I put a AV piston needle in this AV piston needle. So once we close it, once we putting the syringe there, pressure, we close it there. So the pressure from the from the compartment, it increases the saline and it is monitored in the manometer. This is a manometer. We connected this. This is a simple method. We can that this is the patient. We have done the fasciotomy. You have done it. We have immediately do the fasciotomy. You have the myoglobular urine. This is a study we have conducted. So guidelines for the interpretation, if it is less than 20 millimeter of normal, more than 30 millimeter of mercury, tracheous fasciotomy. In hypotensive patients, those who are hypotensive, if it is 10 to 30 millimeter mercury, we can do the fasciotomy. So renal parameters increased renal parameters cases to 625 cases, and myoglobinuria in 74 cases. Comfort pressure increased in more than 500 patients. We have so decompartmentation done in 480 cases. Required 1 or 2 dialysis, the patient improved well. When we take out all the necrotic tissues or the fluid collection, and the patient recover earlier. So surgical intervention is in 84 cases taken as a control. There's a refused surgical intervention. Most of the patients say that I don't want any do surgery. In that case, we are taken as a control, and in those cases the prognosis is so very bad, and they required more number of dialysis. The surgeon is not willing to be a big one thing that we have to do the bleeding time, clotting time, and blood is ready along with this. And then we can subject it for the fasciotomy. The patient improved with adequate fluids and blood transfusion, and 1 or 2 dialysis recovered. This is the study we have done it. And the surgeon is, some of the surgeons not willing to do the fasciotomy in these patients. We put a 11 blade in multiple puncture sites. We make that is let out the fluid from the compartment. We do the multiple level that is 11 blade. We put a multiple nip along with this local anesthesia. We put it so that relieves the pressure, and the patient is improved well. This is a study, we have original study, we have done it. See, this is the fasciotomy done. for some of the patients. So they wound healing is very good in these patients. Suppose if it is leave it, they go for the gangrene. Sometimes they go for the amputations. So early intervention of this the pressure compartment, the patient recovered well. This is how you can monitor the output. So how much is urine output is that you can notice it. So this is a patient with a cellulitis with a and the urine output is more than 2 liters. So early management of compartment symptom in snakebite cases by surgical intervention or intravenous sodium bicarbonate infusion, myoglomerulin patient improves outcome, reduces the mortality. So in a recent study published in AKI, you know that now the biomarkers are predicting the long-term outcomes. They have usually apart from this NGL, beta 2 microglobin following the acute kidney resulting from the snakebite. This is a study from the KS reports. So recent paper you all noticed that is Anila has done a wonderful study on biopsy diagnosis, acute tubular necrosis, number of patients 64, interstitial nephritis 56, ATI with ATN that is 28 patients, renal cortical necrosis alone is 11 patients, thrombotic microangiopathy number 1, mesangial proliferative glomerulonephritis number 1. This was reported by the Chuk at the time itself. So IgA nephropathy 1. So pigmented const were present in 32 patients. This is the immunochemical staining, confirmed hemoglobin myoglobin pigment in 18 and 11 cases. This is a study, pathological study published in IJN by Anila. This is from this Sri Lanka study. They diagnosed what happened. The snakebite patients, once we treated, it is okay. But we also have follow-up for that, given the references. So most of the patients who developed a chronic intestinal, that is 37% of developed chronic kidney disease, who developed 5 patients had ESRD, 4 had stage 4, and 11 patients have stage 3. Duration of renal replacement. Why there is a CKD in these type of patients? It has been observed that the treatment modalities, even months, so months, 1 month, the patient in the ward, but recovering, slow recovering will be there. In this type of patient to go for the kidney injury in later stage. In our study, so these are the poor prognosis, elderly, cortical necrosis, severe hemorrhage, complications, septicemia, mortality is very high. Those patients in our study, that is what those patients on who expired in our ward, we asked the PGs to do the biopsy. I told them, when I was a student, we do by the biopsy by the Wim Silverman needle. Now later TrueCut came. We asked the PGs to do whenever the patient expired, they asked them to put a biopsy, and we found that most of the patient had the biopsy report came as a ATN with that tubular cast formation pigment. That is our study, and since the pages are doing in a dead body, most of those are medullary tissues are there. All the patients are subjected to postmortem because the government has ordered the snakebite patient who died, they give 10,000 rupees for their family. So they required the postmortems. Then we collected the postmortem cases also. It found that is a hemorrhagic spots are seen in the kidney and the cortex as well as in the medulla. These are the studies. But in our study, 5 years I followed till in medical college, till my retirement. All the snakebite patients, we used to ask them to come, and most of them are very well. Only some of the patients have the hypertension. I don't know what is the cause for this hypertension, but 5 years follow. It may be due to, my observation is maybe due to partial cortical necrosis or delayed recovery from the snake bite, or because of the autonomic nervous system. The case reports have shown that hypopituitarism, pituitarism is in the case studies have been given these, but in our study is only few patients had this hypertension and mild renal failure, not the severe renal failure or CKD in our study. 5 years follow-up for that. Thank you very much, sir. Thank you. Thank you for giving me the opportunity.
Thank you, sir. Thank you for that short and excellent presentation of your experience. Now the floor is open for comments and questions to the professor. Sir, so to set the ball rolling, the question is TMA, the instances of TMA following snake bite seems to be higher on your case. It's about 48 patients in your series, sir. TMA management is in snake bite, is it any different from what we have now with complement mediated TMAs and other forms of TMAs, sir?
Yes, sir. Yes, sir. Because those days you know that the availability of the histopathology and then the availability of drugs is very less. With the availability, we have given this anti-snake venom and the blood transfusion and the FOB are given. Now they are doing this plasmapheresis also. Now they are.
Hemodialysis, is it better or PD, sir, for these patients in your experience?
Because most of the patients referred in the late night or the late, so we must not delay this. So we put it. What is the problem is the hemorrhage. Hemorrhagic bleed, sometimes hemorrhagic bleeds. We installed the sodium bicarbonate in this, or they make the patient bleed as hypertonic. The BP is normal. We put it in hypertonic and the recovery is very good. So PD is early management. So because peritoneal hemodialysis, we have only 2 machines are there at time. There is no technician, and we had to prepare all the things. But for that, when the patient is having severe profuse bleeding, then we take for this hemodialysis. Otherwise, the peritonitis our report in the acute diarrheal disease and acute snake bite was a very good response. I presented a paper in the Indian Society of Peritoneal Dialysis also and published in the IJPV.
Thank you, sir. Dr. Rajagopalan, sir, you put up your hand. Would
Good
you
evening.
like to go ahead?
Good evening. Thank you, Dr. Mohandas, Dr. Venkatesh.
Thank you, sir. Very happy to
When
be on.
in our PG days in Madurai Medical College, we used to see a lot of snake bite, snake envenomation. There we used to monitor the requirement of ASV by just doing bedside clotting time.
Clotting.
What is how do you assess the quantity of ASV required? Is there any difference in the practice now than what we used to do, or is it just eyeballing the clotting time and then go ahead with ASV?
As per these recommendations, we have to see for this clotting time, and then we have to give ASV according to that. The recent studies have shown that giving ASV, this is giving higher doses of ASV that also leads to other complications later. I told you that the Vimala has done this study.
Yes, sir. Yes,
This
sir.
is a problem. This is a problem with our government. So this I was standing before the DMS and then the officers because maximum number, the number of cases was very high because it's a referred center. Number of cases are very high. I used to left and right, medical ward. We used to left and right the ASV. And the government asked why you are purchasing this amount because the scarcity of ASV at the time. And government then I have to stand before them the justification of the ASV use ASV use in this patient. Then we adopted the low dose strategy, and also then only the government put an order. All the PHCs, they have the anti-snake venom, they be given that. Usually clotting time is the ideal to monitor this, giving this anti-snake venom. So patient is having profuse bleeding, still clotting time is not that adequately. In our experience, that ASV has to be given, not in high doses. Even we given this 10 ml or this vial is more than sufficient.
In your experience, has there been any situation where there was lack of ASV totally, no supplies at all, but still we managed to treat these snake envenomation patient?
Yes. Very short period. It's not because we have reported this. I presented in the directorate meeting the same thing that and the number of cases. I'm given my statistics to them, and at the time we used to conservatively we had to treat with the saline with sodium bicarbonate with the antibiotics and watch blood transfusion and the FFP, because now the components are now available. Those days not available FFP. With that I managed some of the patients.
So obviously there used to be more morbidity and mortality without ASV, right, sir?
Yes, definitely, sir. The recovery is very delayed, sir. Recovery is very delayed. You know that the snake, we focus on this only on the renal parameters. Hematological complications. Some patients have this bleeding in the brain also. They present with bleeding in the brain because we do postmortem for all the patients, and bleeding in the brain also. So we have noticed some of the patients.
Did you have any problem with kidney disease with crate or cobra envenomation?
Not at sir. Cobra, there is no, nothing.
Thank you, sir. Thank you very much. Thank you, Venkatesh.
Thank you, sir. Are
I
there
have
any
a
further?
question.
Yes, sir. Please, sir. Go
Sorry,
ahead.
it is. Thank you, Dr. Mohandas. It was a wonderful
Thank you, sir.
talk. Just leading from the question Dr. Rajagopalan asked about availability of snake venom, anti-snake venom in Tanjore Medical College. We have a very personal story. One of our classmates used to live near the fields, and rest of the group had gone for a holiday, a Kodaikanal trip, I still remember.
Yeah.
We stayed back, some of us stayed back. But anyway, this gentleman was bought in the night. He hit the snake. He identified the snake as the cobra. He brought it on the bike, he came. The sad part of it was there was not enough anti-snake venom. And we ambu bagged him because there's not a ventilator. And he unfortunately died. And that was, it's always stayed with me for all this time. So that's why now I think anti-snake venom is freely available. Correct, sir?
In all primary health and also the government has given, if the case is referred to TMCH, they have to report to the public authorities as to why they are referring it. This is a thing as Dr. Sundaraj's friend, you know that Sulochana farm vacuum stream.
Yes.
Sulochana's husband, Padmanabhan, pathologist. He was in pathology. He was bitten by a snake because they are staying in the quarters, in the TMCH quarters. So, biochemistry professor, and his husband is Padmanabhan. At night he used to come by walk. He bitten by a snake. And he was not first noticed. Immediately went to casualty, taken injection, and the bleeding time, clotting time, perfectly is normal. Then started having this clotting time prolonged. And the Raja is very close to his friend. And they noticed it's a snake bite. As he told, snake venom is not available at the time, unfortunately. He immediately was rushed to Velur, where he was saved. After that, only recently he died. That is a pathetic situation. Some of the times we have pathetic situations. pathetic situation.
That is the thing. Another thing, question I just want to ask, sir, is like the identification of snake. It is quite important, isn't it? Or it
Very,
doesn't
very,
matter
very, very
nowadays.
important.
Really
Very
important, yeah.
important. Very important, but because of venom is
Yes.
polyvalent venom, the vaccine is only that. That is a research they have done that 18 in the different. Today's Hindu, the article is very nice article. No antibiotics and injecting the camels. So some type of camels they put it and take in the blood and they are research
Yeah, I
is
saw that
so
nanobodies. Yeah.
no antibiotics. That is very good if it is comes because we can say because any amount of anti-snake venom they cannot neutralize this. This is the guidelines given by this government on 16. Our study because now the cases have been reduced because everywhere there is a medical college, everywhere the anti-snake venom. The workload is very less now.
Okay.
That was a very good presentation, Dr. Mohandas. For
Thank you,
the
sir.
benefit of postgraduates, the other important complication, not so well reported from India, but a few cases from Kerala and mostly from Thailand, is the pituitary necrosis.
Pituitary necrosis.
Hemorrhagic pituitary
Yes,
necrosis. Just like Sheehan syndrome or pituitary apoplexy, the hemorrhagic complication presents. In this part of the country, in PGI, we see a lot of hemotoxic snake venom. As I've shared Professor Chug's original work on this. But of late, more and more we see neuroparalytic snake bites, especially crate is worst offender because the bite is so small. Any case which comes like LGB or acute neuromuscular paralysis, the residents are asked to keep this differential diagnosis very high on the cards because they may not be aware of this history. Many times the parents don't even come out with the history, and when we search very carefully, we may find very small fang mark, and empirically many times these patients have to be treated as a snake envenomation.
That is
Right,
more common. Whenever the patient brought neuroparalytic in the summer, because all the village people will lie down outside
on the floor,
house,
yeah.
and they have this. We noticed some of the cases of the neuroparalytic. There is no history of snake bite because they are not aware of it, the snake bite at the times. Like viper bite, we can't, the blood parameters immediately cannot show this prolonged or anything like that. Vascular lesions will not, if there is here the small snake bite that clotting times prolonged or the small cellulitis with lymphadenopathy, we suspect so viper bite. But neuroparalytics, there is no evidence except the clinical features. That is the thing more common.
So thank you for an excellent presentation.
Thank you.
And also thank you for being there for the needy patients, right? I think you saved many lives, just by your presence and, in a resource limited setting, right? Where, you have limited choices. I think it's very special, for that. Two comments that I want to add. One is that it's very interesting.
Because of this, most of my PGs have joined nephrology.
Right, sir.
Kannan Baba, SPS, and KG's Sivakumar. All of my postgraduates, they have done wonderful work in the snake bait, and all of them have done the postgraduates under my unit, and they have done the PD, and so they have been well trained. So interested in nephrology, they got the nephrologist seat.
Great, sir. There are also two other things. One is I note that very interesting. There is a significant, it's acute interstitial nephritis is very common. We can expect ATN because of the hemoglobinuria, hemolysis, and all that. But acute interstitial nephritis, there are quite a number of cases in your list, that you showed. Yeah, so I think that's one thing I think people must note that, venom can result in immune reaction and cause
Reaction, immunological mediated. That is a
exactly.
paper was presented by this Anila in IJN recently.
Right, sir.
See, this
Yeah.
is not an acute she has done.
Mm.
She told that not acute cases were recorded,
Mm.
but the referral cases of this snake bite, if the patient, as we used to say acute renal failure not recovering 3 or 4 weeks, immediately we do biopsy and what is the cause for this? Likewise, they are done, they causes the acute interstitial nephritis.
Right, sir. The second comment, sir, is that like IASC, there is a scientist by name Karthik Sunagar. He published the paper in Science. They are the one who are developing that synthetic antibody to the snake venom,
Yeah.
and the Hindu thing that you referred to.
Yeah.
And so I post his website, his laboratory website in the chat. So it may be interesting to people if the original work is going on, to find the novel solutions to treat snake bite. These are very effective, broad, and can be useful. And one another comments is that like some investigators from University of Mysore, there are no human studies yet. They've used disulfiram. Disulfiram is a zinc chelator. So since matrix metalloproteases are important in the pathogenesis, so if you chelate the zinc, then metalloproteases they don't function. They showed those to be effective in a mice model. They published this paper in PLOS 2021. So something like that. I don't know why they've not taken to clinical. Very commonly, what happens is that these basic scientists they do studies, and then they don't know how to connect with the clinicians or how to take it to clinical trial. They don't. So there is a big gap between the scientists and the doctors. So suggestion to to the younger nephrologist or others in the group here is to take something like that. Maybe do a small clinical study. Mostly, so that's maybe there may be a simpler solutions, or even if it improves outcomes by a little bit, that could be something to think about. Thank you again, sir.
Thank you. Thank you for the opportunity, sir. Thank you.
Mohan, very good. Congratulations.
உங்களை தான் சொல்லிட்டு இருக்கேன் நான். நீங்க தான் because of you only they are asking ASV. You only fight with Dean and get the ASV for us. I thank Dorraj sir and S.C. Bose, who was because I was very alone and bombarding all the persons. Dorraj, as a captain, he came and helped me posting the postgraduates. Most of the postgraduates are very happy. They are very happy, and they trained in the peritoneal dialysis.
Government worried about the cost of ASV.
ASV, yeah.
It is 400 rupees when I was there.
Yeah.
When they were purchasing from outside. When it was produced in King Institute, it cost only 40 rupees.
40 rupees.
Yeah.
We had a discussion with the DMS, no? You only replied for that. Why so many cases? Because 800 cases of snake bite, nearly 600 or 0.6.
900 plus.
900 plus. I shown
only 2 deaths. 900 plus. They suspected that ASV is taken out. TMCH and treated outside.
It's outside, out there.
Because we used to follow that emergency clinics of North America. You classify the bite as grade 1, grade 2, grade 3, 10 vials, 20 vials, 30 vials. So it was very expensive for the government. But of course, you have given me the support and I gave him the reply and he shut his mouth.
They closed this King Institute that is from this Ooty. They closed this.
Parts, yeah.
Yeah, first institute.
That Manaka
That's
Gandhi was a minister. She closed it.
Yeah.
Sir, if there are no further questions or comments, can we conclude the session, sir?
One last one, sorry, Dr.
Yeah,
Venkatesh.
please go ahead.
I just wanted to end on a lighter note. They were talking about my first experience with snakes was when I joined as first year, and during ragging at 1 o'clock in the morning, one gentleman caught me on the third floor in Fleming, and he said, "Come with me." So I went inside, and he was the only person who got ICMR, I think, project money to study something about snakes as a medical student. So I entered the room, and there was this 8-foot snake which was going around the room like this, and there were another 3, 4 snakes and one cobra in a cage.
Captain knows very well about it.
And he said, I jumped on the stool. He said, "Don't you jump on the stool, you get down and hold the pant." So he tied one pant on end and he said, "Hold it." I said, "What snake is this? It's going to bite me." He said, "Shut your mouth, hold it. Don't ask questions." And then he told me it was a rat snake. But anyway, that was a frightening experience.
Captain knows it. Captain was the person who put the fellow in trouble.
The other, the lighter vein, one of the boys went with his girlfriend. You know, those days, a lot of cashew nut
Mundri
trees.
totem.
Cashew nut trees. Something bitten in his back.
Oh no.
He thought she's pinching him.
இல்ல பத்மநாபன் சொன்னேன் நானு நம்ம சுலோச்சனா
அது ஒண்ணே இது பையன் ஸ்டூடெண்ட் that his girlfriend is pinching him. The second bite, then only they noticed the snake. DLA was assistant then, DAP. He was brought to casualty, then we was treated.
So it must have been a Nagini. Just kidding.
Pardon?
Must have been a Nagini. Thank you.
Thank you. Thank you, Mohan.
Thank you, sir. Thank you.
Thank you, Dr. Mohandas. Thank you.
Thank you.
Thanks, everyone.
Thank you, Venkatesh.
Thanks for your presentation, sir. Thanks for your time and expertise. Then we will end the meeting on that note. Thank you all. Thank you for joining.
Thank you, sir. Thank you, sir.
Thank you, Venkatesh.
Thank you, sir. Thank you.